Welcome everybody to this symposium on mitral valve replacement, expanding patient options, and even in case of mitral annular calcification. This is a sponsored session from Abbott, and I will be in this room together with great colleagues. On my left side, Leonard Conradi. On my right side, Paolo Denti. Nicola will be presented afterwards because he has to do something more important. We have online Paul Soraja, and the chat master is Mariana Damo. The learning objective of this session is going to provide the best pathway for mitral regurgitation management. We want to learn about the early commercial transcatheter mitral valve replacement experience, and also discuss and discover what are the options for patients with mitral annular calcification. So without having any more further delay, I leave the word to Nicola, who will tell you how to interact with us.
Yeah, thank you, Francesco. I think the most important is that this session is for you to address your questions, your clinical needs. So thank you for physically attending this session with us. You are of course encouraged to ask any questions you would have. Two ways to do that: either physically, you can stand up and go to a mic, and we'll give you the opportunity to ask your questions. If you want, you can also ask your questions through the app by just typing it, and I will see that on my screen. But we have also a blended audience, so we have people remotely connected, and those people will also probably ask questions. I will see on the chat, and I will make them public.
Thank you so much, Nicola. So again, it's a great pleasure to have a great colleague from across the ocean, Paul Soraja, who is connected online. I see you well. You're very elegant. I don't think the audience see you still. Can we project? Okay, now they can see you, how elegant you are. Make sure you are all, do you have trousers or you're doing this in underwear like I've done for all my lockdown? Show us.
I will not.
Demonstrate us. You don't do it. Okay, that's it. So Abbott, next time, don't invite my son, he's an idiot. Okay, Paul, the floor is yours.
Thank you, Francesco, and good afternoon, everyone. And I certainly wish I could be there in Paris, and want to thank EuroPCR and Abbott for this great opportunity. It's, by all accounts, I hear the meeting is going extremely well, and congratulations to all of you. So I've been asked to speak about optimizing the patient journey for primary and secondary MR. Here are my disclosures. Now, when it comes to mitral regurgitation, we know that despite many recent advances in the world and in the world of transcatheter therapy, that this condition remains undertreated. This is a study that was led and published recently by Professor Marie Serrano in Lancet, and it described the outcome and treatment of about 1,300 patients with mitral regurgitation. And importantly, in this study, only 1 in 7 had any type of surgical intervention. And among these 1,300 patients, heart failure occurred in 2/3, and there was excess mortality across all subsets of patients. And what's really remarkable is that this is a community-based cohort study in Rochester, Minnesota, where the world-famous Mayo Clinic is, and there's incredible access to care there. So if only 1 in 7 have surgery in Mayo Clinic, one can only imagine how much worse the undertreatment is in the rest of the world. And so when we think about options, transcatheter mitral therapy has really emerged as a viable option for many patients with commercial approval in Europe, and many technologies also available in the United States. And the options of repair and replacement are often considered. And in a broad sense, repair is often really attractive because it's widely available. It's usually TF. It has a short length of stay. It typically does not involve any cumbersome prosthesis. And we know that from at least some studies that transcatheter repair is life-saving in selected patients. So we're here in a symposium to talk about replacement. And why would we want to do replacement? Well, replacement simply affords the opportunity to have no MR. And I think that is a very attractive proposition. And when we're thinking about, well, when are we going to take that leap towards doing replacement and pursuing the OR? Well, it starts with looking at the repair options and looking at the anatomy. And we know that we consider repair in patients with the appropriate clinical factors, whether it's FMR or DMR. We think about the operator's experience and the center's experience. And then we think about the anatomy. And certainly there are ideal patients for repair. But as the anatomy becomes less ideal, more challenging, or even contraindicated, replacement becomes a much more attractive proposition. So when we're thinking about repair versus replacement, if there's an inadequate result with TEER that is suspected, and there's suitable anatomy on the CT with no LVOT risk, and the access is suitable, then TMVR becomes a very attractive proposition for complete relief of MR in these patients. And certainly, I'm talking about inadequate results, and the SUMMIT randomized trial will test TMVR in patients who are also eligible for TEER. And those results hopefully will be out sometime soon in the near future. Now, the symposium here this afternoon is being sponsored by Abbott. And in fact, the Tendyne prosthesis made by Abbott is really the prototypical TMVR device. It's the leading technology. We have over 1,000 patients in the world now treated in the world with the Tendyne valve. It's a trileaflet bioprosthetic valve. It has a contoured outer frame with a very broad range of sizes. It has a valve that is stabilized by a tether and apical pad, and importantly, it's fully retrievable and repositionable, and there's no requirement for cardiac pulmonary bypass or rapid pacing during its deployment. The way we determine whether a patient is a candidate for the Tendyne prosthesis is that we start with a CT scan. We look at the anatomic measurements in terms of size. We do a virtual fit assessment in systole and diastole. We look at the neo-LVOT, and we also use the CT to help guide the procedure. We do simulated fluoral on FOSS as well as SLVs to look at how the valve will look when it is going in during the procedure. And what's really nice about this technology and this approach is that it gives a lot of certainty when there's in fact uncertainty about the clinical indications for mitral relief. So here, if you look here, this is a patient on the left-hand side. This is a patient with severe secondary MR. There's a bit of a short posterior leaflet, and one might argue whether or not this is treatable with TEER therapy such as MitraClip. I believe it potentially is, but there also is a risk of residual MR. And what this can then be treated with is a Tendyne valve. And here, within 30 minutes, the valve is deployed and the MR is completely relieved, and the patient can go home in a few days. So it gives a lot of certainty to that MR relief when the anatomy is less clear. And we can do this in a broad range of patients. And we're going to talk about that in this symposium. We'll cover patients with severe MAC. This is a patient who had a previous annual flex surgical ring. And we also have patients in whom we've previously treated with TEER therapy, in whom we can also do TMVR with a Tendyne prosthesis. Some of these indications are off-label, but it gives you an idea of the broad range of anatomy that can be treated with this technology. And the results can be achieved with a very safe and durable outcome. This is from our paper that we published in JACC a couple of years ago, the first 100 patients. And at 2-year follow-up, 93% of the patients who are still alive had no MR. There was no evidence of structural valve degeneration. 5 patients had mitral valve reintervention, and otherwise the relief of MR remained durable. And importantly, this was safely done. The acute results, valve implantation, 97%, technical success, 96%. There were only 3 patients where the valve was retrieved. But importantly, there was no procedural mortality, no strokes, no emergency surgeries, no need for ECMO, and the 30-day death rate was 6% with an O to E of, or objective of expected mortality of 0.76. So a very safe procedure. And this is an important point to make because there's a lot of criticism that can sometimes come our way in terms of the transapical access, but in appropriate hands, it's a very safe procedure. Now, the ongoing Summit trial is being led in the United States by Gaurav Alawadi and Jason Rogers. And this is enrolling patients with or without MAC. And there's a randomized arm in which Tendyne is being compared to MitraClip. There's also a severe MAC arm and also a non-clip arm in which patients who are not eligible for TEER will also be enrolled. And this trial is ongoing, and hopefully we'll have results for us soon. You can see the primary endpoint here, which is a one-year endpoint for all of the arms. Now, if you're ever wondering how this technology can really impact patients' lives, please go to our website at mhif.org. You'll see this story of my patient, Larry Walters. This past Friday was his 7-year anniversary of living with a Tendyne valve. We implanted him 7 years ago, May 13, 2015. He's had an EF of 30% for almost 9 years. And with Tendyne, the EF has stayed at 30%, but he's NYHA class 2. And he's an incredibly grateful patient. He's been on dialysis for 5 years. But this just gives you an idea of how we can impact our patients' lives, which is really an amazing story. And he's the oldest living U.S. patient with a Tendyne valve currently. So key points here: under treatment remains high for MR. We can get high implant success rates with Tendyne with no operative deaths, no surgery in the EFS. The MR reduction is sustained, the symptom improvement is significant, and there's a broad range of anatomies that can be treated. And thank you very much for this opportunity, and I look forward to the discussion.
Thank you very much, Paul. And I think your presentation opens the door for some discussion, which will be led by you, Nicola.
We don't have yet questions coming from our colleagues listening to us. Maybe, Paul, I would have maybe one question to you. You perfectly explained that you have in your decision-making process a kind of cutoff that drives your choice between TEER or TMVR. And let's discuss mainly about primary MR. Is the life expectancy of the patient an important criteria of choice here when you make your decision? In other words, does the fact that you have different potential options for reinterventions with TMVR on one side and TEER on the other side drives your choice towards one of a solution or the other?
Thank you very much for the question. Yes, I completely agree. The life expectancy is a very important decision point. And that's simply because we don't want our patients to outlive the technology we're giving them, and that is the prosthesis. And, we often think of patient prosthesis mismatches, things related to valve hemodynamics, but patient prosthesis mismatch also occurs when there's not matching of life expectancy to the durability of the prosthesis. So if we fully expect that a patient with DMR would outlive the prosthesis, then we really have to take that into consideration. I think for secondary MR, it's a relatively easy question. Most patients with secondary MR don't live 10 to 15 years. But for primary MR, I think you have a really good point, especially if they're young. They can go many, many years. And that question becomes very important, especially when we have options such as TEER available.
Paul, we have one of our colleagues, Dr. Kassar, on site, who would like maybe to detail a little bit more how technically challenging is Tendyne procedure.
Well, it's actually a very well thought out procedure by now. With over 1,000 patients, technically challenging. It's actually relatively straightforward. I think we've worked really hard to make it that way. The transapical access is somewhat different from TAVR in that it has to be very accurate and precise because the access determines the tether and pad location. But otherwise, it is really a no-drama procedure. And that's because it's fully deployable and fully retrievable. It goes with other technologies in terms of like TEER, where one can fully assess the result before fully releasing it. And I think that makes it a very attractive proposition. Most of the time, and we have this documented in our paper, that the total procedure time is less than 60 minutes, which for a patient receiving a mitral prosthesis is very attractive because most mitral surgeries, bypass time is longer than 60 minutes. So from that standpoint, it's a very straightforward procedure.
Maybe one question for one of you guys, Francesco, Paolo, or Leonard, as cardiac surgeons. Most of the heart team started their experience with transapical access and technique of controlling the bleeding after transapical access at the time of TAVR, but years ago, and then we lost this experience. So if a heart team would like to start their experience with Tendyne, would you consider that the cardiac surgery team needs a dedicated training on that, or it's corresponding to the average skill of any cardiac surgeon?
I think it's a good question because somehow TA access has faded out until now, right? There's not many centers doing relevant numbers of those procedures anymore, and those colleagues of us that have that experience are few. So that in addition to the fact that there is a distinct difference from transapical TMVI to TAVR in that you're dealing with another tissue substrate, right? We're not dealing with a hypertrophied, thick, strong counter that the LV in aortic stenosis is, but you're dealing rather more often than not in a dilated, thin-walled, hypokinetic ventricles. Plus, the diameter of the delivery is somewhat larger than the latest TA catheters that we had was. So first of all, these are, is a combination that seems doubtful. On the other hand, Paul nicely showed that there's extreme or high procedural safety of this procedure, which I have to admit was surprising to me at first. Now, of course, we can speculate on why that is. There are probably many factors influencing that. The fact that this early experience has been gathered in expert hands is one, for sure. But from a design standpoint, the tether fixation on the apex certainly is a hemostatic agent in itself, and I would say that has also to do with the procedural safety that we're seeing.
Yeah, thanks, Leonard. I think there is an additional point is about training and education. This procedure is trained on a simulator which is also including the bursting preparation, which is actually could be a problem in the future where this procedure goes away from the hands of these guys who have been doing transapical TAVIs. Anyhow, let's go forward because I think we have a very important topic. So thank you, Paul. Stay online because we are going to involve you again. The next topic is going to be how to do with mitral annular calcification.
Thank you, Francesco, for the presentation. Dear colleagues, thank you, Abbott, for giving me the opportunity to show what we do in San Raffaele. Finally, it's real, finally, we are able to treat this type of patient. What is MEC? MEC stands for mitral annular calcification. The best way to see it intuitively is CT scan. This is a short axis view of a mitral valve affected by a severe calcification of the posterior part of the annulus and also of the trigone. In the past, we didn't know how to stratify patients regarding the quantity of calcification on the annulus. Also in surgery, it was difficult to us to stratify patients and give subject a number in order to understand how much severe was the calcification. In this paper, Guerrero showed us a number that gives us an idea of how severe is the calcified annulus. The higher is the number, the bigger are the calcification. To have this number, we have to sum other characteristics of the annulus, which are the calcium thickness, the calcium distribution, and if the calcium distribution arises more than 270 degrees, you have what is called a horseshoe MEC, and then the trigone involvement or the leaflet involvement. What are the treatment options of this type of patient? You have to imagine that MEC patients are pre-selected not to be only a MEC patient, but they are also other comorbidity. So these patients are pre-selected to have high mortality, not because of low cardiac output, but mainly because of the MEC the complication of intervention, and also other pathologies. The surgical mitral repair or replacement has been proposed and is still available, but there are only few series in the literature. Small series, but carries out, as you can see here, high mortality, up to 28%. As you can see from this paper from Campertier or David, which, as you know, are really famous and skilled operators, you can remove the calcium from the posterior leaflet and then put a patch in order to exclude the new chamber and then repair the valve. Other techniques proposed are to put directly needles into the posterior leaflet if not calcified or into the atrium. As you can understand, this could lead to a six-fold increase of the rupture of the atrioventricular groove, which is a life-threatening complication. You have to imagine that you cannot repair a rupture of the atrioventricular groove because it's not a net rupture, as you can have with a wire when you push too much in TAVI procedure. But you have weakened tissue, and so when you have such a complication, these patients are usually dying. As you can see here, also if the patients survive, 1 year mortality in surgery is 15%, 5 year 38%, and at 10 years, only 20% of these patients are still alive. What about percutaneous transapical or transfemoral implantation of a TAVI balloon expandable valve? This technology has been proposed, and in the literature there are at least 400 patients treated in this way. This valve is implanted into the neck transapically or transfemorally. These patients are carefully screened not to have complication, especially outflow tract obstruction. Imagine that when you implant this type of valve, you have the movement of the anterior leaflet towards a small LVOT. The risk so is the obstruction. The mean mortality of this 400 patient is 16%. And in the first series, you have an obstruction that was 40%. Nowadays, we are able to go to 13%. In the MEC registry done by Guerrero, which is in particular spent his research on this topic, at the beginning of this experience, they had a mortality of 31%. And in the second 58 patients, they have a mortality that goes down to 19%. So we are able to screen and to have better results, but still high mortality, high risk of embolization that lead to conversion to surgery. The last and less promising procedure is the hybrid procedure. So you put a balloon expandable valve, surgically modified with a pericardial patch around the stent, directly into the mitral under direct vision. And you fix it with some points into the atrium or into the annulus. Again, only few patients are involved in this type of procedure. The case report, in any case, carry high mortality, but again, mean you have 20% of 30 days mortality and 30% in 1 year. The big Achilles heel of this procedure are also the leak, because you are not able to fixate completely the valve, and so you can have leak around the prosthesis. What I want to propose you, a game changer, the Tendyne result. Has been recently published, the last name, Paul Soraja, this experience on only 20 patients. So if you want to compare the first experience in the MEC registry. So the first 20 patients have a 95% of success and a 30-day mortality of 5%. 1 year cardiac mortality 20%. If you take only the whole mortality is 40%, but you have to take into account 2 suicides. Only 1 patient experienced obstruction that was treated with septal ablation. Immediately, no leak were present. So I think that these results are completely different from what we already seen in other technique. Another important information that I had from Abbott, which is a personal information that I can disclose, that in the Tendyne MAC cohort, they had such beautiful result that they want to enroll it in a normal arm. I want to show you a real case that we have done in San Raffaele, one of the 3 cases that we have done with severe or moderate to severe MEC. As you can see here, other than the number, which is 8 of Guerrero, you can see that it is a shoe horn completely MEC. As you can see from this slide, there is a big calcification. This is a long axis of the heart, and you can see that it's completely surrounded by the calcium. The procedure is slightly different from the normal one, since we use a balloon of 28 millimeters, which is the dimension of the inner frame of the valve, in order to accommodate the valve afterward, the Tendyne valve afterwards. The procedure is completely reproducible nowadays, and other than this step, we are able to do the whole procedure in a fast and rhythmic way. This is the final result, with no obstruction, no paravalvular leakage, and the patient clearly went well. As you can see here, the conformation of the valve is a little bit restricted. It's not as usually completely around the atrial cuff. And it is important during this type of procedure to measure immediately the LVOT obstruction if there is present. Because with this valve, if you have problem, you can retrieve the valve and the patient can be supported in other way or can have other option. So the purpose of this is to take you into account Tendyne in MAC patient. So what I show you are different results from other techniques, which are in any case still available, but the mortality of 5%, no leak and no LVOT obstruction, I think that are different, and you have to take this into account when you have to deal with this patient. Thank you.
Thank you, Paolo. We have one question, but that is more general regarding the screen fail rate and potential options to reduce that. Maybe we'll address that later, but it's just for our colleague who has that to know that we'll address that. Maybe dealing with this MAC subset of patients, as this technology initially was not developed for MAC, but there was an extension of indication, one might have concerns regarding a higher rate of PV leak. In the case example and in the clinical theory that you presented, it's not the case, but can you elaborate a little bit on that?
Clearly, the valve was not designed for this, maybe, but as a matter of fact, there was a clinical need, especially in the US. In fact, they were the first that they embraced this technology. The technology by itself, this is something that I grabbed from Francesco's words. It's very clever since you divide the fixation and the sealing. You have an atrial cuff, and then you have a fixating on the apex. So this is the reason why maybe this valve can have such good result in different anatomical pathways. In the MAC, and this is again a communication, we are still implanting patient that has rheumatic valves, which are affected by stenosis and regurgitation, which in case can be similar to MAC, but there are other pathology. So the broad pathologies that this valve can work on is very big, and despite at the beginning was not used also for feasibility and safety reason. I think that nowadays, once we screen the patient that has good measure to implant a Tendyne valve, the procedure at least has to be attended, because again, if you want, you can retrieve the valve.
Maybe, Paul, you can clarify one point in order to make our colleagues having the clear ideas about indication in the context of MAC. We can treat patients having MAC and suffering from mitral stenosis and mitral regurgitation, either isolated or combined, right?
Yes, and so it has been used in patients with both MR and MS. Currently, it's not indicated for MS, but in the clinical trial in the United States, we have an inclusion criteria that allows MS and MR. Right now, among the patients who have MAC who get Tendyne, 2/3 to 3/4 get balloon valvoplasty beforehand to help facilitate the implant or to address stenosis. So it does cover that broad range of anatomy, and currently is being explored as an indication here in the United States.
Thank you. Maybe, Leonard, one technical or anatomical, I would say, issue that could come at the time of screening, considering the pathophysiology, any risk of potential impossibility to expand the valve that would represent a contraindication to use this technique in MAC patient, or by pre-ballooning you always succeed to afterwards deploy the valve?
Good question. It comes down to the question whether the Guerrero classification really applies to this valve, because it obviously wasn't developed for that. One could imagine that there would maybe be a correlation between incidence of PV leak and the extent of calcification down the Guerrero scale. But we don't know. But typically what we do in planning, we have a barrel shot kind of assessment of the mitral annular subvalvular portion of the valve to assess whether there is calcium which would interfere with the inner stent portion of the frame. And Paolo has told us that a 28 balloon usually would make enough space for that. Now, we don't know much about recoil, but from a surgical point of view, the trajectory of the calcium on the leaflet is different compared to a TAVR maybe, because it's a perpendicular way to displace calcium in the aortic valve, where it's a tilted way on the mitral leaflets. So I could see that with that ballooning of a 28 plus the radial force of the stent, it would work even if there was calcium in the barrel shot view extending or being anticipated to extend towards the inner stent frame part.
Francesco, do we have time for one more question or not?
Always.
Yeah, okay. So one maybe Alison Duncan, who has great experience with Tendyne, want to challenge one of you. Can you explain how difficult is it to size the annulus in MAC, and can you explain the rationale of oversizing?
In any case, we found out that the sizing is not such challenging. From CT scan, you have all the image that you need. Clearly, you have to find the lowest portion of the valve, and you have to measure where the calcium is not present. In this way, you size the valve, but more important is to find out if there is the presence of obstruction. So it's more cumbersome to measure the possibility of obstruction of the flow tract rather than to screen for the positioning of the valve. We also know that now that valves behaves slightly different, so we know how to implant virtually the valve and better calculate the VOT.
Great, Paul. I see that you cannot see Paul, I think, but I see Paul, and he agrees. He's nodding. So good answer. I hope that this is a good answer for Edison. We move forward to clarify what are the data at the moment. So Leonard will summarize the clinical outcomes.
Okay, thank you. So the task is to see what we have learned so far with just over 1,000 implants worldwide. These are my disclosures. So what have we learned? We have learned, and we've seen from Paolo and during the discussion, the technical feasibility of the procedure is high, and it is safe, at least procedurally, with these really remarkably low procedural complication rates that you see here. We also know that the acute results down to 30 days are good or acceptable. At least 6% mortality, I think, is more than acceptable in a patient population that has an STS around 8-9%. And what we've also heard from Paul, you've seen this bar graph before, is that the elimination of MR is usually excellent, regardless of the underlying pathology, with rates that you see here. At 2 years, there's virtually no patients, or very little, that have clinically relevant MR left, even though this is obviously not a pair-based comparison here. So as I said, the acute mortality would be okay with 6%, and I think that's really true, but let's be honest, this is not all the data we have. At 1 year, this mortality climbs to 26%. At 2 years, there's 39% mortality in these patients. Now, it seems obvious that this comes from the underlying pathology or comorbidities that these patients have, and is an expression of the overall increased risk profile of those. But we could also ask yourself, are we treating the right patients here? Have we learned how to properly select the patients? And I would say we haven't entirely, at least. We know where it will work acutely, but does that justify the implantation? And I think it's an important topic to be discussed, and I would invite all of you that are interested to join this Thursday's presentation by one of our co-workers who will talk about an expanded population of patients, almost 200 patients that receive this valve. And he will also show you predictors of mortality at 90 days. Little surprisingly, age is among them, right? Who elderly patients are likelier to die than younger ones. That is a no-brainer. But there's also a hint regarding right heart function, maybe expressed in the fact that pulmonary hypertension is also an independent predictor of mortality in this procedure. And towards the lower end of this table is an encouraging fact that institutional experience exceeding just 2 cases is protective of adverse outcome, meaning that there is definitely a short learning curve, and it is in line with what Paul and Paolo have been saying, that this is a rather straightforward, easy to learn procedure for an intact heart team at least. What we've also learned from this expanded population of now over 190 patients, which is the largest so far reported series with this device, is that complications such as stroke and myocardial infarction are encouragingly low, I would say. And also, what we've been discussing earlier, that the apical access site complication rate is fairly low, around or below 1%, even though, of course, increasing numbers of patients also means increasing numbers of sites and would likely mean increasing numbers of less experienced operators. So that is one encouraging thing that we find in this data set. What would be next? Some of you may know that there is a post-market registry running called the Resolve MR. It is a classical post-market registry, as I said. The only inclusion criterion would be use of the Tendyne according to instruction for use. So I have to say that severe MAC that we've been discussing would be an exclusion. We're going to enroll 200 patients at a good number of sites here. And as I said, it's going to look for results after Tendyne intended to be used according to the IFU. I can say that we're good on track with the number of activated sites, and we're even exceeding the anticipated enrollment. So obviously, and we've said this a few times now, there is an indication for this valve, there is a clinical need, and colleagues are looking for this additional therapeutic option. We're going to follow patients for 5 years follow-up, also to assess things like durability of the valve, of course. And then there is a tender registry. Now you might ask yourself, why do you need another registry? This is an investigator-initiated one by colleagues from German sites. This is an all-comers, intended to be an all-comers registry, so it would naturally also include off-label indications, such as prior annuloplasty, for example, or severe MAC cases. And it is aiming to investigate acute results, and this is just an overview of what it means to include off-label. There's a good 25-30% proportion of patients that are off-label within this trial. So let me conclude. We've learned that Tendyne TMVR is procedurally safe and highly effective regarding MR reduction, but there is increased mortality at follow-up. We have to be honest to discuss this and ask ourselves, do we know enough about patient selection here? Do we not know enough about the degree of frailty, for example, that patients can have and still be rectify a procedure like that? We know now that predictors of 90-day mortality is age above 80 years of age. We know that pulmonary hypertension plays a role in predicting outcome, but we also know that there is a flat learning curve of just over 2 cases, even with colleagues or heart teams that are late to adopt or later down the road to adopt this procedure. And we have registries that will address these questions, and hopefully we'll have more data soon to answer some of these. Thank you.
Lennart, we have one of our colleagues who would like to know a little bit more about what drives reintervention after Tendyne initial implantation.
Okay, so first of all, I would say reintervention on a Tendyne is a rare event. It is probably in the double-digit number. I bet it probably has more numbers. I have personally intervened on only one single case, which needed retensioning of the tether which is again a rare thing to do, but it adds, I guess, to the safety profile. Yeah? If you have dislodgement of the valve, either acutely or at midterm, there is a way to fix this. Think about other valves that fix on the annular level only. There's not much to do if you have, except for conversion to surgery, maybe. If you have such a situation. So overall, I would say again, it's a rare event, and at least in selected cases, there are things that you can do about it.
Okay, maybe one more general question we had previously, but I think it's worth address now before we close is, what is roughly the screen failure rate because of small neo-LVOT with this technology?
Yeah, that's also a very relevant and hard to answer question because it really depends on what your input of anatomies is. I would say that at experienced site like yourself or Paolo's or Francesco's, the screen to implant ratio has become quite favorable nowadays, but a large part of that is because we've learned more about pre-screening, so-called pre-screening. So when I think back on our very early TMVI experience, we would, whenever there was a patient who would disqualify for surgery, for risk, for example, and would disqualify for TEER for anatomical reasons, for example, we would just more or less blindly submit. And little surprising, we had a huge screen failure rate because, of course, hypercontractile small ventricles will never accommodate such a large implant. Right now, I would estimate our screen to implant ratio to be around 1:3 to 1:4. Maybe it's a little optimistic, but I think it's around that. But it's certainly a field that needs attention. I think Abbott has in part already addressed it with the low profile iteration and is addressing it with, I think, 13 different sizes or stent configurations. But certainly, yes, that continues to be one major limitation of the therapy as a whole, I would say, of the whole field.
And also I would add that, as we know, LVOT, it's not only a geometrical problem, but it's a dynamic problem. So we know nowadays how to deal with patients which is at risk of obstruction because we know how to manage this with drugs or volume. So the reason is we send pre-selected patient and also we know better how to treat eventual obstruction.
Maybe second question from the same colleague around this topic for you, Paul. In those patients at risk of a small neo-LVOT, is lampoon being an option performed prior the Tendyne implantation? And maybe for those who are not specialists, you can briefly describe what is lampoon.
So lampoon is a technique that is used to lacerate the anterior leaflet to make space for the neo-LVOT. Yeah. And it is, there's a surgical predicate for it, obviously, for surgeons who take care of the anterior leaflet when they're doing surgical mitral valve replacement. And it's catheter-based radiofrequency delivered therapy. The challenge with Tendyne for lampoon is simply that when you look at the frame of the Tendyne valve, the skirt goes to the edge of the frame. And so taking care of the anterior leaflet with lampoon doesn't completely address LVOT issues because you still have the skirt extending to the edge of the frame that can cause LVOT obstruction. It's unlike the Sapien, lampoon done for Sapien, where there is a skirt-free zone. And so we often talk about the neo-skirt LVOT. So it's a little bit different and often not as helpful for this procedure.
Okay, so thank you, Paul, for this last contribution. I think it's time to recollect a little bit what the informations have been flown during this discussion. First of all, this was a symposium dedicated to the single transcatheter valve, which has the largest experience to date. And there is a reason for that. It's not only that it was before others, but also because of its versatility and because of the design. Specifically, for instance, probably is the best platform to address calcified valves because of what Paolo was describing you, that there is a net separation between the sealing, fixation, and the valve function. So every component is separated. So this valve has a much stronger radial force than others, and it is because it is also delivered through the transapical approach. We learned that the procedure is safe, effective when the patient is well selected. We've been talking about patient selection and patient pathways. I think Paul Soraja has been proposing as a kind of an algorithm to take decisions. Some basic rules, obviously, is work in progress. And this work in progress will only go forward if we think like Paolo, having the Tendyne in your mind. I don't know if you have to do it physically or whatever, but you were really convincing to all of us. And last but not least, I think the message was that this procedure is not only feasible, but also learnable. Only 2 cases to overcome the learning curve. So have this procedure in mind. Again, if you don't want to do it physically, at least think about it and have fun for the next PCR events. Thank you very much for your attention.